Department of Medicine grand rounds, and welcome and thank you to all of you who came on -1 billion degrees weather. It wasn't that bad. You were on the roads this morning. I don't know what's going on, but we're all here. Thank you very much. And we have a special guest from the University of Utah who will be introduced in a minute, so we're really excited about that. Today is an interesting day in medical and science history. If you can see me and you can read these letters, it's probably because you have good eyesight. The acuity of your vision is pretty good. And we know this because you probably have a fraction of 20/20 or close by with the glasses, and we know that is the Snellen fraction. And the chart that you go to see when you go to the ophthalmologist is the Snellen chart, Snellen. Hermann Snellen was born on this day back in 1834. Now, if you're learning what she has to tell you today, is because there's several waves that are activated in the process of learning. And we know that because William Gray Walter, who was born on this day back in 1910, linked particular brain waves to the action of learning. He actually also developed a robot, which was the most advanced robot at that time, which he named Testudo. Testudo is in Latin for turtle. So you can imagine this very, very, very slow robot. We're going to hear a little bit about glucocorticoids today and bone loss and the impact on the bone. We know about the impact of glucocorticoids on organs because somebody took the time to look at organs and many, many, many autopsies. And one of the premier pathologists who really put pathology on the map as a recognized science was Baron Karl Rokitansky. And he was born on this day back in 1804. He was very well known for his descriptive pathology. He performed over 30,000 autopsies himself. A lot of interesting people died on this day as well. André Cornan, who won the Nobel Prize and shared it with two other people for heart catheterization, died on this day in 1988. On this day was the death of James Hardy in 2003, for the first human lung transplant, which he performed in 1963. And George Nicholas Papanikolaou, which many of you have heard of, who developed the pap smear, died on this day back in 1962. And with that, I'll leave you with Dr. Ravenel from the Division of Rheumatology, who's going to introduce our special guest.
Good morning. It is my pleasure to introduce Dr. Karla Miller. She is visiting with us from the University of Utah in the Division of Rheumatology, where she's an assistant professor. I had the pleasure of meeting Dr. Miller several years ago now as part of my recruitment to the University of Utah to be on faculty there. But since that time, she has proven herself to be an amazing colleague and friend. But on an academic note, she is extremely talented. Her patients just absolutely adore her. And she's also found a niche in the medical education world at the University of Utah. She currently leads a cohort of medical students where she takes them from first year throughout fourth year and guides them throughout medical school. She also has found a major niche in the field of rheumatology. Rheumatology has become very vast and we deal with a lot of different issues. However, we like to be very comprehensive of dealing with our patients. One of the issues that's come up in the last 15 to 20 years is the fact that so many of our patients are on high-dose steroids for various reasons, and she's really found an interest in glucocorticoid-induced osteoporosis and bone health. To this end, she has been invited to the FDA Advisory Council to be a part to come up with treatment guidelines for such issues. She's also been involved and has established a very popular clinic at the University of Utah where she sees primarily patients just for bone health reasons. And so patients come from all over the state and actually all over that area to be evaluated by her for bone health issues. It started out being more glucocorticoid-induced, but now has very much expanded because of her expertise. She's also published various articles in the field in glucocorticoid bone health loss, and also has presented several abstracts at our American College of Rheumatology based on quality and other issues. Currently, she has developed some things within the EPIC healthcare system, or EMR, at the University of Utah to make sure that there are standards when it comes to patients being on high-dose steroids and their bone health being addressed. She graduated from the University of New Mexico medical school, and then went on to do her training and residency and fellowship at the University of Utah, which she has stayed on faculty. It is my great pleasure to welcome Dr. Karla Miller. I am unfortunately sad to say that she has come to about 50 degrees less than she was in Utah today, but welcome anyway.
Can everyone hear me? Very good. Well, thank you very much for that very generous introduction, and thank you for having me here in your freezing cold, beautiful city. We have a balmy 65 degrees in Salt Lake City yesterday, so it was quite a change. So I wanted to start this talk talking just a little bit about the history of glucocorticoid-induced osteoporosis and the epidemiology of bone loss related to this drug, and then the glucocorticoid actions on bone, followed by the approved therapies for glucocorticoid-induced osteoporosis and the current guidelines for the prevention and treatment of osteoporosis, and then go into some controversies that apply to osteoporosis in general. I really enjoyed the history lesson that we received this morning, and just we started thinking about glucocorticoid-induced osteoporosis as early as 1932 when Dr. Harvey Cushing, who was a neurosurgeon at Johns Hopkins, first described an association between excess endogenous glucocorticoids and fractures. This was while he was studying pituitary adenomas. Several years later, Dr. Philip Hench and colleagues introduced prednisone for the treatment of rheumatoid arthritis, and 1 year later, he went on to receive the Nobel Prize for his work with using prednisone in rheumatoid arthritis. And only 5 years after that, Curtis et al. Published in JAMA vertebral fractures resulting from prolonged cortisone and corticotropic therapy. So unfortunately, we know from early on that these drugs have major adverse effects. Based on large population-based studies, we know that glucocorticoids are the most common cause of secondary osteoporosis, and unfortunately, fractures are their most common adverse effect. Approximately 1 million Americans require long-term oral glucocorticoids, and a recent meta-analysis showed that up to 4.6% of postmenopausal women were reported as taking glucocorticoids. We also know that 30 to 50% of our chronic glucocorticoid users will experience an osteoporotic fracture. Regarding the epidemiology, we know that the bone loss in GIOP occurs very rapidly. It occurs within the first 3 to 12 months of therapy, and that fracture risk, along with it, increases as well within that first 3 to 12 months. In one large U.S. study that used claims database, we found increased risk of almost threefold here for vertebral fractures, almost twofold for hip fractures, and also increases in non-vertebral fractures and any fracture. We also know from these studies that the severity of the bone loss increases with increasing glucocorticoid dose, and this elegant study showed that there was an increase in fracture risk pretty much at any given dose of steroids, the greatest risk being with doses of 7.5 milligrams of prednisolone and above, with a relative risk of 5-fold in vertebral fracture and 2-fold in hip fracture. Doses, even low doses, 2.5 to 7.5 milligrams, were associated with elevated risk. And doses of less than 2.5 milligrams, which most of us feel like is a very small and low dose, was also associated with an increased risk of vertebral fracture. We also know that the severity of bone loss increases with increasing glucocorticoid duration. So there is an effect from cumulative dose of steroids. And one of these studies that I had mentioned earlier looked at the increased risk of hip fracture of 7-fold and vertebral fracture of almost 17-fold. We know also that our fracture risk decreases rapidly upon glucocorticoid withdrawal, even within 1 year, but it is not completely reversible. We know that previous glucocorticoid use for greater than 3 months is also shown to carry an increased fracture risk, and this is even separate from bone mineral density. And this was found in a large meta-analysis of 7 cohort studies. This is, I think, one of the favorite studies that is looked at when we discuss glucocorticoid-induced osteoporosis, and this was published by Van Stahl many years ago. But we know that in our patients who are treated with chronic glucocorticoids, they tend to fracture at a higher given bone mineral density. And this shows T-scores at the lumbar spine and at the femoral neck and incidence of vertebral fractures. And the squares here, I'm not sure if you can see these too well, but these are patients who are glucocorticoids, and these are patients who were non-users of glucocorticoids. That in any given bone mineral density, the risk was much higher for those patients who were on glucocorticoids chronically. So this definitely caused us to start thinking about risk that was not associated with bone mineral density alone. Obviously, there are other effects that glucocorticoids must have on the bone that is separate from bone mineral density. There is, interestingly, also a small increased risk in hip and vertebral fractures with high-dose inhaled glucocorticoids, beclomethasone or equivalent drugs. And though it was a small increased risk, it does appear to be real, especially with doses greater than 1,500 to 1,600 micrograms daily. And this remains significant after adjusting for confounders such as COPD severity. Topical, intranasal, ophthalmic, and also appropriate adrenal replacement is not associated with an increased risk of fracture. So we have many studies now that show this increased risk. How well do we do as clinicians at identifying and preventing and treating osteoporosis? Well, unfortunately, we also have many studies that have shown that we do pretty poorly in general as clinicians in managing this problem with glucocorticoid-induced osteoporosis. We have multiple studies now that show that in patients who are on chronic steroids, we tend to order DEXA anywhere from 42 to 50% of the time. In these patients, we recommend calcium and vitamin D 25 to 55% of the time, and offer prescription therapies 22 to 42% of the time. And this included subspecialty practice, such as my own rheumatology, which is very unfortunate. We like to think we do a better job. So I'm going to move on at this point to the glucocorticoid actions on bone. When we talk about osteoporosis, it's important to think about the components of bone strength, which are not just bone mineral density, but bone quality. Bone mineral density is much easier for us to take a look at with bone densitometry or DEXA. Bone quality is more difficult, and we do use our clinical risk factors to give us hints into the patient's bone quality. Bone quality is comprised by rate of bone remodeling, microarchitecture of the bone, microdamage accumulation, and the degree of mineralization, as well as trabecular connectivity. We've really moved away in recent years from just using DEXA alone to make a fracture risk assessment on our patients, and now we look at the whole patient and we include their clinical risk factors in determining the risk of fracture. We know that many patients who have osteopenia never go on to fracture, and what really makes this difference is what are their clinical risk factors for fracture, such as glucocorticoid use or a diagnosis of rheumatoid arthritis. So we use those things to help us with assessment of bone quality. This is just a slide to remind us about normal course of 200 days. And osteoblasts start this process by creating an erosion cavity in the bone over 3 to 4 weeks. Then mononuclear cells prepare the bone surface for the osteoblast then to come in and replace the resorbed bone with new bone matrix. And this process is longer. This takes 3 to 4 months. And then there's a resting period, and this cycle begins again. We know that glucocorticoids really affect trabecular bone to a greater extent than cortical bone from the previous studies mentioned. And trabecular bone is very interesting in that it has a very high surface to volume ratio, and remodeling occurs at the bone surface. So 80% of the remodeling in our bodies occurs in the trabecular bone. And this makes it so that trabecular bone responds much more rapidly to changes in bone balance. We know that steroids over time decrease trabecular thickness, they decrease trabecular volume, and also trabecular connectivity. So I know this is a busy slide, but this is mostly to illustrate that glucocorticoids have both direct and indirect effects on the bone, and I'm going to focus on the direct effects on the bone cells themselves in the next few slides. So we know glucocorticoids' predominant effect is on the osteoblast. There is an early and continual decline in both trabecular osteoblast number as well as function. There's also a decrease in osteoblastogenesis induced by the steroids and an increase in apoptosis of these cells. This disrupts also signaling pathways that are important for bone formation. And the overall result is a decrease in bone formation. And this is really the hallmark pathogenetic feature of glucocorticoid-induced osteoporosis. And this is different than postmenopausal osteoporosis, where the primary hallmark is increased bone resorption. So this is a low turnover osteoporosis compared to a high turnover osteoporosis. Glucocorticoids also exert an effect on osteoclasts, especially early on in treatment, and this is maybe why we see that rapid decline in bone density during that first year of treatment. We see increased trabecular osteoclasts, and there is also an increase in rank ligand expression and a decrease in osteoprotegrin expression, leading to osteoclastogenesis and bone resorption. But with long-term therapy, there is an overall decrease actually in osteoclastogenesis, but an increase in osteoclast survival. So you have a relative maintenance of normal numbers of osteoclasts in the bone, where you have decreased bone formation, accounting for most of the loss thereafter. And this is just a reminder of the rank ligand pathway. Rank ligand is expressed from osteoblasts, and rank is a receptor on the osteoclast. When rank binds to this receptor, it induces osteoclastogenesis, osteoclast differentiation, and we have more bone resorption. Osteoprotegrin is also secreted by the osteoblast in a balanced way, and when it binds, it inhibits binding of rank ligand and decreases bone resorption. So we have two phases of glucocorticoid-induced bone loss. We have the rapid phase, which is mediated both by osteoclastic bone resorption coupled with the decreased bone formation, and we see this 6 to 12% bone loss in the first year, and then a later phase that is slower but continual, and this is caused primarily by a major decrease in bone formation over time, and that's about 3% of bone loss yearly thereafter. I wanted to talk a little bit too about the osteocyte. This is a bone cell we only in recent years have been more interested in, especially regarding issues of bone quality. And the osteocyte is a cell that looks a lot like a neuron, maybe a little reminiscent of neurons, but these cells are actually very important in sensing changes and triggering the appropriate response to microdamage in the bone. And we've also learned in recent years that glucocorticoids exert effects on the osteocytes themselves. They decrease increased apoptosis. This disrupts the osteocyte canalicular network and results in a failure of these cells to detect the signals that stimulate the replacement of damaged bone. And this likely explains a lot of what we're seeing in decreased bone quality related to steroids. I also wanted to mention that glucocorticoids not only have these direct effects on the bone, but they also have some indirect effects that are important to think about. They have indirect effects on the neuroendocrine system where they decrease that steroids and growth hormone. They have effects on calcium metabolism, all which lead to negative calcium balance and increased bone absorption. And then they have very detrimental effects of long-term use on muscle. And this, unfortunately, can lead to myopathy, muscle weakness, and increased risk of falling in our patients. So in summary, we know that the bone loss with glucocorticoids, it occurs quickly, and that it occurs in trabecular bone to a greater extent than cortical bone. We know that fractures occur at a higher given bone mineral density in our patients who are on steroids, and that there is an increased risk with higher daily dose and with higher cumulative dose. And there's also a slightly increased risk with high-dose inhaled corticosteroids, which is something important to think about. I'm going to move on now to the currently approved therapies for glucocorticoid-induced osteoporosis. I like to use pictures whenever possible, and currently the approved therapies include the aminobisphosphonate and teriparatide for GIOP specifically. And I just wanted to remind everyone of the mechanism of action of the aminobisphosphonate, where they are taken up into bone with very, very high affinity, and then taken up into the osteoclast and result in osteoclast dysfunction and apoptosis, and thereby having their anti-resorptive effect. Teriparatide is an anabolic agent. It works on the osteoblast. It is similar to parathyroid hormone, and it is in low daily doses, it actually stimulates bone formation through its effect on the osteoblast. So currently FDA-approved therapies for GIOP prevention and treatment are the aminobisphosphonate, alendronate, risedronate, and zoledronic acid, as well as teriparatide. These are studies that were looked at for both prevention and treatment. I've highlighted in different colors the ones that were prevention studies only. But just overall to show that the primary outcome in these studies was bone mineral density at the lumbar spine, and the secondary outcomes were bone mineral density at the hip and vertebral fractures, as well as non-vertebral fractures. It's important to note that these studies were not very long, so most of them were just 1 year in length. Some of them were extended to 2 years. The longest here was an extension of the teriparatide trial out to 36 months. So it is very difficult when the trials are of that duration to show differences in non-vertebral fractures and even in fractures in general at the spine. But all of these studies met their primary endpoints of showing an increase in bone mineral density at the lumbar spine or prevention of bone loss. And I also wanted to point out that zoledronic acid and teriparatide came out at a later time. These are newer drugs compared to alendronate and risedronate. So these studies were active comparator studies. They were not placebo studies because it was not ethical to not treat our patients with something. And then in regard to vertebral fracture, we did see decreases and trends to decrease vertebral fracture in all of these studies except for in the zoledronic acid study. And again, remember that this was comparing bisphosphonate against bisphosphonate, and there was no difference, but overall fractures were decreased. There was just no difference from the comparator. I also wanted to talk a little bit about the newest drug on the market for osteoporosis is denosumab, and this is a specificity for rank and right now it is already FDA approved for postmenopausal osteoporosis. It's just in phase 3 active comparator studies for the treatment of GIOP. But it is a potent inhibitor of bone resorption. It's also an anti-resorptive agent. So at this point, I will go through the current guidelines for the prevention and the treatment of GIOP. There are many guidelines out there. The guidelines that I will be focusing on are those put out by the American College of Rheumatology, not just because I'm a rheumatologist, but also because they're, I think, the most comprehensive, and those, and also talk about the American Society of Bone and Mineral Research addition to those guidelines. Oh, here we go. So I will start with the lifestyle modification and counseling. And it's important to remember these things when we talk to our patients about osteoporosis prevention. Calcium and vitamin D is recommended. At this point, we recommend to our patients that they take a total of 1,200 milligrams of calcium, but that is a total of oral plus supplement. So most patients who don't have special dietary needs obtain about 600 milligrams of calcium in their diet just from the regular foods they eat. So all that is really required in addition to that would be one 600 milligram supplement. Oh, yes.
As well as if you...
Oh, sure. Vitamin D supplementation, the current recommendation is 800 to 1,000 international units daily. Weight-bearing activity, smoking cessation, avoidance of excessive alcohol, nutritional counseling, obtaining a baseline DEXA, and then also a baseline vitamin D level. In my clinic, we do follow a baseline height as well, and we look for height loss and assessment of prevalent fractures, especially in patients who do complain of height loss. We do consider x-rays of the spine to assess for vertebral fracture. Calcium and vitamin D. I'm not going to spend a whole lot of time on this. I know this is a controversial issue. And there are some studies on that raise concern for calcium potentially increasing cardiovascular risk when taken in a supplemental form. And I think for this reason, most osteoporosis specialists are recommending that you take calcium in a low-dose supplement, 600 milligrams a day, and you take the rest of your calcium in a dietary form. We do think it's absorbed better that way anyway, and dietary calcium doesn't seem to carry the same risk that has been implicated in these other studies with supplemental calcium. It is a low-cost intervention, low toxicity. There have been 2 meta-analyses that show significant increase in bone mineral density at the lumbar spine with calcium plus vitamin D3 versus calcium alone or no treatment in GIOP. But there is little fracture data regarding calcium and vitamin D, and I think that's where the controversy always comes. We know also that though we consider it to be necessary, it is not sufficient in our patients receiving chronic glucocorticoids. So the current recommendations for postmenopausal women and men over the age of 50 start by determining the patient fracture risk using FRAX. And the 10-year risk of major osteoporotic fracture, which is a clinical vertebral, hip, forearm, or humerus, 10% or less is considered low risk, 10 to 20% is considered medium risk, and 20% is considered high risk. We do consider multiple clinical factors that can increase your risk category. So if you're on a higher daily glucocorticoid dose, we can move categories, higher cumulative dose, or if you have a declining central bone mineral density measurement that is considered significant. I'm not sure about how many of you are familiar with the FRAX algorithm, but this is something that we are using much more commonly now to assess fracture risk, and it is a way of assessing absolute fracture risk. And so in our patients, we plug in the age, we plug in their sex, and then it goes through a number of clinical risk factors that are very important to fracture risk, and you plug in the bone mineral density, and you're able to select your DEXA machine here. And in most of the time, we do have to convert our pounds to kilograms and inches to centimeters here when we're plugging in weight and height. And then this calculates a 10-year fracture risk for any major osteoporotic fracture and a 10-year fracture risk for hip fractures. And right now, the World Health Organization, the National Osteoporosis Foundation recommend that if you have a major osteoporotic fracture risk of greater than 20%, that is an indication for treatment in a patient who is osteopenic, or if you have a fracture risk of greater than 3% at the hip, that is also an indication for treatment. So for our patients in this category who are low and medium risk by FRAX, we consider therapy if their anticipated or current glucocorticoid use is greater than or equal to 3 months. For high-risk patients by FRAX, we start therapy at any dose or duration of glucocorticoids, remembering that these are patients that you would treat anyway, even if they were not on glucocorticoids. So in those who are at low risk by FRAX, so less than 10%, and on glucocorticoids such as prednisone 7.5 milligrams a day, or if they're medium risk at any dose, the approved medications for treatment are alendronate. 35 milligrams once a week can be used for prevention if the postmenopausal female is on hormone replacement at the same time, or if your patient is a male. 70 milligrams weekly was more effective in postmenopausal females who are not on hormone replacement therapy concurrently. Risedronate 35 milligrams once weekly and zoledronic acid 5 milligrams once yearly are also approved and effective. For our patients who are high risk by FRAX, you can treat with any of the above mentioned medications for any glucocorticoid dose or duration. And teriparatide can also be considered as a first-line agent if you have a high-risk patient by FRAX and their glucocorticoid dose is 5 milligrams or greater. This is also a consideration for starting treatment. For our premenopausal women and men under 50, this is a much murkier issue in terms of how we treat our patients. The fracture risk is just not well defined for this population, and that limits our FRAX applicability, and there is an age threshold on FRAX at 40 years of age. There's also a paucity of evidence for the treatment of GIOP in this population. Unfortunately, the randomized controlled trials for our currently approved therapies just had very small proportions of premenopausal women and men under 50, 7 to 22%. So, and there's also just a general lack of fracture risk reduction data in these patients. We also know that our risk factors for fracture in this population are also less clear, and the risk of current and previous medication use to a fetus in this population is also unknown and of concern. So the American College of Rheumatology made recommendations in premenopausal women and men under 50 only in the case of existing fragility fracture. They felt that in patients who had not had a previous fragility fracture, there was not enough evidence to make a formal recommendation. And it is important to note that this doesn't mean a lack of a formal recommendation should not be interpreted as no treatment for your particular patient. I think when it comes down to it, you decide between you and your patient whether a therapy is indicated based on what their risk factors are. So for women of non-childbearing potential or men under 50, prednisone 5 milligrams a day for 1 to 3 months of bisphosphonate can be used. Prednisone greater than 3 months, bisphosphonate or teriparatide is recommended. Women of childbearing potential Bisphosphonate or teriparatide is recommended in patients who are taking 7.5 milligrams a day or more for greater than 3 months. And teriparatide is added, especially in light of the fact that it is shorter acting, and if there was a pregnancy, this is a medicine that could be readily stopped. In patients who are taking less than 7.5 milligrams daily, the ACR was not able to make a consensus in those patients. I also wanted to talk about the additions from the ASBMR. They agreed completely with the American College of Rheumatology's recommendations, but they also brought up some cases where they would have an alternative recommendation for this population, and I think this is important to consider. And from their standpoint, if a Z-score in a premenopausal woman or in a man under the age of 50 was -2 or lower, they would consider treating. And also in a patient who had significant decline in their bone mineral density related to ongoing glucocorticoid therapy, they would also consider treatment in these patients. And they also recommended a preference for drugs that had shorter half-lives, such as teriparatide. At the time, they made the recommendation for possibly considering denosumab instead of a bisphosphonate in women of childbearing potential. But unfortunately, denosumab, since that time, has been put in category X for pregnancy. It is not appropriate for use in patients who are considering pregnancy or are pregnant due to animal studies showing skeletal anomalies in fetus. In terms of monitoring, we do recommend serial bone density testing. It is appropriate in the first year after the glucocorticoids initiated to have a bone mineral density done 1 year later because of the rate of change being so high. But thereafter, we typically do the standard every 2-year monitoring of bone density. And it's also important to note that Medicare only pays for every 2-year bone density screening. And then you want to consider annual screening of the vitamin D, annual height measurement to look for height loss, and appropriate assessment of any incident fragility fractures. And then also very important to look at adherence to osteoporosis medications, which is a very big problem in some of our patients. I wanted to touch a little bit on the FRAX limitations in GIOP. The FRAX tool does not include a dose response, and so it's just a general risk assignment without taking into account what dose the patient is on. So there is a recent physician paper that provides a percentage adjustment based on dose. And then FRAX also only uses the bone mineral density value at the femoral neck. And bone loss, we know, occurs in the trabecular bone first, and we have many patients who have very low spine bone density, but their hip bone density may be less severe. This could result in an underestimation of fracture risk. So there was also a paper published that made an adjustment for those with a major spine-hip discordance. This is the published table looking at based on dose of prednisone, and just what's important to note is what the FRAX calculator assumes is a dose of 2.5 to 7.5 milligrams a day. So if your patient is on more than that, the FRAX calculator will underestimate fracture risk, and if your patient is on less than that, the FRAX calculator will overestimate. And so based on age, there are published percentage adjustments you can make to the final score based on dose. It's also important to note that FRAX can't take into account the frequent intermittent use of high-dose steroids, which also increases fracture risk, but it's just not possible to quantify this. High-dose inhaled glucocorticoid also may be a risk factor, and FRAX may underestimate risk in these patients. And then glucocorticoid replacement for adrenal insufficiency should not be included into the FRAX calculator. This has not been found to increase fracture risk. There is a physician-friendly FRAX enhancement for the spine-hip discordance This is very easy. It's basically a 10% increase or decrease for major fracture for each rounded t-score difference between lumbar spine and femoral neck. So if you have a patient with a minus 1.2 at the femoral neck and a minus 2.2 at the lumbar spine, you can adjust their output by 10% upward to account for that. And this, in a large cohort of patients, did result in significant reclassification of some of these patients. So I'll move on to some of the recent controversies in osteoporosis. And there are some controversies that are specific to glucocorticoid-induced osteoporosis. We know that the studies that are evaluating bisphosphonates in GIOP are of relatively short duration. The skeletal dynamics of GIOP are distinct from those of postmenopausal osteoporosis. We know that chronic glucocorticoid exposure is associated with both decreased resorption and formation over time, leading to a low turnover osteoporosis. Do we need to worry that long-term bisphosphonates, along with chronic glucocorticoid use, is over-suppressing bone remodeling? And this is a concern. We also know that the affinity of the bisphosphonates for bone matrix is very high, but they're not all the same. Zoledronic and alendronate have more of an affinity for bone than risedronate and abandronate do. And we know that bisphosphonates are incorporated into the newly formed bone and have this direct effect on the osteoclast function and decrease bone resorption. But because they decrease bone resorption, they are released from the bone very slowly once they initiate that process. And so they have a very long terminal half-life in the bone. In the last few years, the FDA Advisory Committee for Reproductive Health and Drugs had a meeting to conduct a systematic review of bisphosphonate safety and efficacy, focusing on the extension trials of alendronate, zoledronic acid, and risedronate. One of the major concerns that has been brought up is osteonecrosis of the jaw. And the definition of this, I think, is very important because I feel like in my clinic I have a lot of patients that say, oh, my jaw started hurting and this is why I stopped my medication. And really the definition of this problem is an area of exposed bone in the maxillofacial region that does not heal within 8 weeks. So it's not just a simple jaw pain or jaw discomfort. This is an area of exposed jawbone. And it has been associated with previous or current use of bisphosphonates, especially if there's been no radiation therapy to the craniofacial region. And this here is just showing that area of exposed jaw. This can be seen on a physical exam just by examining the mouth. It's important to note that this is very rare among patients that are treated for osteoporosis. I think the big concern came in patients who are receiving higher dose bisphosphonates to prevent skeletal metastases and cancer. The prevalence in patients who are on osteoporosis treatment is somewhere from 1 to 28 per 100,000 person years of treatment. And there is an association with taking the bisphosphonates for greater than 3 years. So it does seem to be associated with length of use. The most robust data came from a German study that used the Central National Registry, and they found a prevalence of 1 per 250,000 patients treated with oral bisphosphonates for osteoporosis. There is also a possible association with glucocorticoid use, which is confounding. And so just in general, we recommend in our patients that they have any invasive dental work done prior to their use. And so I do ask my patients, are you planning on any major dental work in the next few months? And I would delay my treatment until after that has been done. The other concern is atypical femur fractures. Many patients that come in and say, I saw a commercial on TV saying that my osteoporosis drug is causing fractures. I'm worried about this. And there is also an association, and causality hasn't really been shown yet, but there is an association with these subtrochanteric atypical fractures that have some interesting features where you see thickening and beaking of the cortex. And some of these patients will present with a prodrome of thigh pain and have been on bisphosphonates for a number of years, so it is associated with length of use as well. But in general, it's important to note that subtrochanteric fractures occur. There are 5 to 10% of all regular hip femur fractures, and only 3 to 29% of these have these atypical features to them. They're very rare. They're less than 1% of all femur and hip fractures, and there is an association with bisphosphonate use for greater than 5 to 7 years. But it's also important to remember that the absolute risk is very low compared to osteoporotic fractures that are typical. And it's estimated that a bisphosphonate would prevent 30 to 300 more total fractures than what it would cause. And so it's important for me to remind my patients of this fact because it can be very cloudy for them to process this information. There's also a possible association with glucocorticoid use in these patients. And this is a very nicely done review that was published very recently, just looking at the risk of major osteoporotic fracture and then these other rare events. And these here are major osteoporotic fracture in low-risk women. These are women we would not treat. And then these here are in moderate risk and then high-risk women. And some of these patients we may not even recommend treatment in. And then the risk of osteonecrosis of the jaw in comparison. A typical femur fracture, if you've been on the medication for 8 years, still pales in comparison to the risk of having a major osteoporotic fracture. And I thought it was funny that they also included death by murder and fatal MBA to keep things in perspective. So we always take risks in life and in taking medications, and I try to remind my patients of that. And I do try to keep in mind, though, the real reason why I'm using the medication and try to remember to stop the medication in patients who never should have been started on the medicine to begin with. Also at this FDA meeting, we discussed esophageal cancer. There is definite biologic plausibility. These medications have been associated with esophagitis, esophageal ulcers, and bleeding. But this was in these side effects were in patients who were taking the daily doses. All these studies were looking at alendronate taken 10 milligrams a day or 5 milligrams a day, and we really don't prescribe them that way. We prescribe them once a week in this day and age, and so it may actually be less with the weekly and monthly forms of oral bisphosphonates, and the available evidence is inconclusive. There was a case control study and a cohort study that evaluated the very same population and resulted in opposite conclusions. And then there were smaller cohort studies that have shown no increased risk of esophageal cancer. And then this post-approval analysis of the randomized control trial data showed rates of esophageal cancer that were similar to the background rate. So the FDA's stance on this is avoid oral bisphosphonates in patients who are already at high risk, such as Barrett's esophagus, achalasia, and varices. From this meeting, I think the biggest thing that came from this meeting was really looking at the composite data. Only 2, and these are for not just GIOP trials, these are general osteoporosis trials, the large trials looking at alendronate, risedronate, and zoledronic acid. Only alendronate and zoledronate designed trials where they monitored patients over a phase after stopping drug. And so we have a little bit of insight from those studies. And the interesting finding from that was in the patients who were randomized to continue for another 5 years after stopping alendronate or for another 3 years after stopping zoledronic acid, the patients who continued on therapy compared to the patients who went off therapy, the fracture rates overall were similar. We did not see a major increase in fractures. And so this raised the question as to, is it necessary to continue treatment or prolong treatment in patients greater than 5 years? Should we be stopping and having a holiday, after 5 years of treatment? with bisphosphonate. And so they did publish this data in a New England Journal article that I'll talk about later. But other interesting findings from this, in the patients who continued their bisphosphonate exposure out to 10 years, there were continued increases in bone mineral density at the lumbar spine and maintenance of bone mineral density at the femur neck. In those patients who discontinued the bisphosphonate after 3 to 5 years and were just followed, there were small increases still in bone mineral density at the lumbar spine and small decreases in bone mineral density at the femoral neck, and this was then followed by a plateau, but never down to baseline. So, reviewing this study, they followed bone mineral density in all of these patients every 1 to 2 years, and they found no differences in fracture risk in patients who did and did not lose bone, either by bone mineral density or by use of bone turnover markers during that initial 5-year period. And so when we think about drug holiday, we'd like to know what we should follow during that period. Should we follow bone mineral density by DEXA? Should we follow bone turnover markers? And unfortunately, these were not helpful in that period from the few studies we have. So more studies are really needed to define a drug holiday duration and the surrogate markers of increased risk, such as bone turnover markers or DEXA. There is a study that will be enrolling soon nationwide, called the EDGE study, basically looking at patients who pursue bisphosphonate therapy and then decide to stop bisphosphonate therapy. So hopefully we will have in upcoming years more information regarding how we should do this. The current FDA labeling for the bisphosphonate says in their important limitation of use that the optimal duration of use has not been determined. All patients on bisphosphonate therapy should have the need for continued therapy reevaluated on a periodic basis, and I think this is a fair statement. The panel voted that the labeling should be updated, especially as new information comes about, but that the data did not support an all-inclusive restriction on the duration of bisphosphonate use. So the FDA did publish in the New England Journal this information and raising the question of whether or not we should continue bisphosphonates for longer than 5 years. But many of the clinical researchers in bone published another article in the same edition raising concerns about the design of these trials. These are just a couple trials that we're basing this off of, and they were in the pre-analysis phase. They were designed quite differently. They were designed to look at vertebral fractures and non-vertebral fractures separately, and that this might not be an accurate way to look at this data. And so, interestingly, they did look at the data and determine that there were some risk factors that seemed to be associated with an increased risk of fracture in those patients who did go off the bisphosphonate therapy. And it appeared that patients who had a previous history of vertebral fracture at the start of randomization to go off their bisphosphonate did seem to have a higher risk, especially if their femoral neck T-score was minus 2.5 or less, or in the range of minus 2 to minus 2.5. The number needed to treat was quite low in these patients, as well as patients who had never had a vertebral fracture but had a femoral neck T-score of minus 2.5 after the initial 5 years of treatment and still had this low T-score. These patients were at high risk for clinical vertebral fractures. And so it did seem that there is a subpopulation of people who would benefit from continued therapy. And so they did, based on these findings, make the argument that we should consider continuation of the bisphosphonate in patients at the highest risk of vertebral fracture. And those are the patients with a T-score of minus 2.5 or less at the femoral neck, and in patients who have an existing vertebral fracture in the past with a T-score of minus 2 to minus 2.5 at the femoral neck. Also of note, you can consider a lower dose of alendronate in those who are continuing therapy. About 50% of the patients who continued therapy continued on this lower dose rather than the full 70 milligrams once a week, and there were no differences. So, in summary, we know that the use of glucocorticoids is widespread clinically, therefore GIOP is very relevant to all practicing physicians, and that chronic glucocorticoid use is really associated with a rapid and sustained decrease in bone strength leading to fracture. We know that prevention and treatment of GIOP in clinical practice is suboptimal, and that there are published guidelines and effective therapies for prevention and treatment of GIOP. So, in summary, I always recommend weaning your glucocorticoids to the lowest dose necessary to control the underlying disease, preferably off whenever possible. To estimate your fracture risk and adjust the glucocorticoid dose for spine hip discordance and for the glucocorticoid dose. And then consider prevention and treatment. If your patient is taking greater than 7.5 milligrams a day of prednisone or equivalent in postmenopausal females, males over 50, and premenopausal females or males who are under 50 but have had a fragility fracture. And there are some circumstances where our patients may have not had a fracture where we would still consider treatment, and that is more on an individual basis. And then this is important because I know even in my own practice I often fail to do this. Discontinue the therapy if they're no longer at high risk or if they're off the glucocorticoids and they're only on it for prevention. Thank you.
Thank you, Dr. Miller. Very, very nicely done. I have one question for you. Roberto Pacifici is an endocrinologist and researcher who studies osteoporosis. And in his model, he has found, he believes that osteoporosis is an immunologic disease because when he influences T cells, he can manipulate osteoporosis in his animal model. Mm-hmm. And anybody who does glucocorticoid treatment in patients knows that we mess around with the immune system. Mm-hmm. What is known about that?
No, I don't know. Oh, yes, sorry. I don't know a lot about that aspect, but we do have some interesting data just looking at our rheumatoid arthritis patients. We know that the rheumatoid arthritis is a risk factor for fracture. Just the autoimmune disease itself has an impact on bone density alone, apart from the glucocorticoid use, and I know that the denosumab, which does interfere with the immune system and the rank ligand pathway, is very effective at decreasing fractures, and it also is effective at decreasing erosions in our rheumatoid arthritis patients and bony damage. So I do think that there is a lot of overlap between our immunologic and our endocrinologic systems, but I don't know a lot of detail in terms of the basics.
Thank you. Here then.
One of the real clinical problems with steroids is avascular necrosis.
Yes.
You can see it coming, you sense it's there, you can't prove it early. It seems like you can't do anything about it for the last it's late. Is there any new information about why that happens or any new guidelines?
I think in no specific guidelines that I'm aware of for avascular necrosis in terms of the steroids, except that we would still, this is another well-known complication of steroids, and we would still recommend weaning the steroids to decrease that complication rate. Interestingly enough, though, there is data suggesting that bisphosphonates can be used sometimes to treat the avascular necrosis, and so it's a very interesting thing because, with the other side, the atypical fractures and such, we would withdraw the bisphosphonate therapy and decrease the steroids further because of the association.
In your discussion of the various agents available, you didn't comment on the cost.
No.
And among the various agents, of course, the oral generic bisphosphonates are
by far
the least costly. So why would you want to use the other treatments in the same breath, or just alternative?
Yes. So I think that most of us do use the cheapest generic option, alendronate. There's excellent data for efficacy of alendronate. It is generic. Unfortunately, not all of our patients tolerate
the alendronate well or adhere to it. And so I do think that in rheumatology, certainly we have patients who have esophageal dysfunction due to many of their other conditions, and we have to use IV bisphosphonates because of that. And the IV bisphosphonates actually have come down quite a bit in price and are quite affordable, especially in our Medicare patients. They have not been as costly in recent years. Risedronate and abandronate are now available in once monthly formulations, and though I still always start with alendronate if my patient doesn't tolerate once weekly alendronate for stomach upset reasons, I do sometimes try the oral bisphosphonates in a once monthly formulation. They are a little more costly, but I think abandronate has been much less costly in recent years as well. So it's nice to have options, but you're right. I think our primary treatment is always to start with the generic. Teriparatide, I will say, it's extremely expensive and cost prohibitive for some patients. They try to provide assistance for patients who they have charity programs, and they also have copay assistance programs, but it is still very costly and difficult to obtain, and it's a daily injection, but it is anabolic, and it is the only anabolic we have that's FDA approved so far. There are some that are in phase 3 trials and promising agents that are upcoming, but they will be also very expensive. But there are certainly data that suggests that teriparatide is more effective than the bisphosphonates in glucocorticoid-induced osteoporosis, but it is cost prohibitive, I think, in many of our patients.
Over there, then that's one over here.
Thank you very much. Your introduction to advocacy of medicine.
Yes.
Your speaker introduction to it, you're doing interventions with your ethics and business.
Yes.
Do you mind telling us what interventions you're doing?
I would love to tell you more about that if I was more successful than I have been, but it's really important. I think I initially, like everyone, was very excited. Okay, this electronic medical record is going to help us. It's going to be a good thing. It's going to help us identify patients and treat them, but it's easier said than done. And I've been looking at how we identify these patients and actually make a recommendation based on complex issues like dose of steroids, making sure that we're not triggering an alert based on, inhaled glucocorticoids that are low dose or, and it is very difficult to make these rules in the current medical record we have, which is EPIC. We have to look on what's available on the back end for triggering best practice alerts, and unfortunately they don't have the ability to look at duration, to look at dose in a comprehensive way to cause a trigger of an alert, and so you either end up over-alerting or under-alerting. And so, but we're working on this. Right now, we're kind of over-alerting in our medical system because basically all patients who get prescribed steroids are seeing, it's not an alert, a hard stop, it's just a bright yellow notification saying your patient is on chronic steroids, you should consider ordering this DEXA scan,
Let me extend on that question. So
Yeah.
there are several members of this auditorium, including myself, who serve populations who are often over 50 years of age.
Yes.
And when they receive steroids, it's over 10 milligrams, and it's going to be for more than 3 to 6 months. Some would argue, why not just treat those? Because by the time you do order the DEXA and you repeat the prax and all that kind of thing, you might miss that window in which they have a tremendous effect.
Yes.
So what would you think about that?
So the recommendations are to do that, to treat.
Okay.
So you would start that, and I start my patients at the time I'm starting. If I have a polymyalgia rheumatica patient and I know that they're going to be on steroids for the next 2 years, I start them at the time of their initial visit, but I still arrange for their DEXA because I do want to monitor them over time, and I arranged.
Thank you, because I didn't want the audience to leave here that they have to do the fracks and wait for the numbers and do all that kind of thing, and certain populations who are very obviously should be treated.
Well, even if your patient is low risk by fracks, which is going to, many patients are low risk by fracks, if they're on 7.5 or more, you're still supposed to treat and prevent. So.
Last question.
Have any of the guideline groups tried to address the sort of doubling in myocardial infarction or
Not the ones that I have looked at, not the American College of Rheumatology, and I do think that, no worries, that is important to think about. I do think they did make a statement about not using high doses of supplemental calcium, and I think supplemental calcium is really where that risk is seen, is in patients who are taking excess supplemental calcium. Is it possible that with taking a large calcium pill we are absorbing, we're having a spike in our serum levels that's ending up in other places, not in our bones where we would like it to be ending up? It is ending up perhaps in the cardiovasculature.
So in the Utah clinic, you're eliminating all patients who want tablets.
That's my practice. I have my patients, unless they have specific dietary needs or they're lactose intolerant and they just cannot have dairy for whatever reason. But I talk with my patients. I give them a handout that shows them how many milligrams of calcium are in various foods, so that they can calculate for themselves about how much calcium they're getting in their diet. And I talk to them about nutrition, like how about yogurt and almonds and other, those types of sources.
Well, Dr. Miller, thank you so much for that informative rounds. We have the tradition here that we send people home, our outside speakers, with a bat. It's a Louisville slugger. It says, Karla Miller, Medicine Grand Rounds, University of Louisville, February 19th. There are many uses for the bat. Today, you can just move snow away from your path. I want to leave the audience with a little note. I've been looking at this because my wife just sent me something, and I probably should not bring her back. But basically, this is what it says. And it's two pictures. One is cars covered in snow, and the other one is palm tree. And on the top it says, the best part of winter. And the bottom part says, is watching it from Puerto Rico. Have a good day. Thank you very much.
Thank you so much.
So, don't put that in there.